Welcome. We are live. Jarryd, can you hear me okay?
Yeah, I can hear you perfectly well. Thanks, Phil.
Perfect. So welcome to one of the Health First Group podcasts. We have Jarryd on to chat with today. So Jarryd's based over in Bunbury, over in WA. How are you today, Jarryd?
Yeah, really good. Good weather here today, which is a nice change for winter. The sun's shining, so
Be a little bit cold there during winter, I imagine.
yeah, it does. Pretty wet as well. So it's nice to have the sun shining and a bit of a warmer day. So I think
Nice.
spring's on its way.
Good. So we were just talking about how you're pretty much part of the furniture here at Health First Group. So you've been with us for 4.5 years. Is that correct?
Yeah, that is correct. Yeah, so
And that's pretty early days. So we were working together in Mount Isa, which was pretty much our first clinic. And it was me, you, and Julian, I believe, at the time.
yeah, it was.
The three of us. And you stayed in Mount Isa for a couple of years, and then a couple of years ago moved over to Bunbury in WA. Is that correct?
Yeah, that's correct. So I was at the Mount Isa clinic for just over 2 years. And then after that, transferred to Bunbury to get that clinic up and running.
Did you find a bit of a difference? I guess private practice is private practice, but like, did you find a difference in the caseload when you moved, or is it pretty similar over there to what we used to see in Mount Isa, or not?
So a slight difference. So demographics is slightly different as well. So obviously Mount Isa being a mining town, a lot more sort of miners, that sort of thing. Demographics wise, yeah, sort of just your general population, couple of tradies, things like that as well.
Yep.
And then just sort of your stock standard knee pain, back pain, which you pretty much get everywhere.
Yeah. Mount Isa's a lot of workcover and sort of orthopedic type stuff up there, isn't there? From the mine. So I guess there's a bit of a difference. Bunbury would be a bit more of a, I guess, what I would classify like a normal sort of caseload, I guess, for private practice. So obviously 4.5 years, a lot's changed from a Health First Group. We've gone from sort of one or two clinics to 18, 19 clinics. So yeah, well, I guess what's changed from your side? There'll be some positives and negatives, I guess. Hopefully more positives and negatives. But yeah, tell me about the change that you've witnessed, because it's always good to, I obviously have my opinion on the change, but it's always good to hear it from an employee's perspective.
Oh, it's been a good change. Like, it's amazing how quickly it's taken off and sort of exploded. Starting obviously 4.5 years ago, it was Goldie and Mount Isa. Then obviously Kalgoorlie opened up after that, and then everything's just sort of snowballed after that. Seen some really good changes.
It's really beneficial from a sort of numbers in the group perspective. Like, we've got that sort of local internet now flow where people can kind of reach out and talk to each other, and this is one of the reasons why we're trying to sort of do the podcast as well, is to kind of internally for people to learn a bit more about each other as well, so that, you know, internally and externally we can kind of reach out to each other and benefit, I guess, from like an economies of scale perspective. And you've been doing a lot of work with the new grads. They've been pretty much under your wing last year and this year. So yeah, tell us a bit about the sort of new grad setup and the sort of mentoring that you've been doing with those guys.
So I started with the new grads last year, February. So sort of first time I started with them. Previously, sort of when I was working in South Africa, I did a little bit of mentoring for new grads there. So sort of just help sort of carry on with that. Really enjoying that, sort of mentoring the new grads, getting that up and running. So initially they're all pretty nervous, shy, and as we get going with the session, so sort of the first 6 months we do weekly catch-ups, then sort of moves to fortnightly, 2 hourly, and then sort of just an hour each fortnight, bringing clinical cases forward, any issues they're having, just building their confidence in general and making them better clinicians. So it's just great watching them grow, their confidence grow, their caseload grow.
It's interesting, isn't it? It's quite scary for them, and I'm not sure. Like, what's your opinion on? Do you feel they're sort of adequately prepared for private practice? How do you find that? Because I find they're often a bit of a sort of blank slate at the beginning, because they've sort of got this wide breadth of knowledge in a lot of different areas, but then sort of putting it into practice is a challenge. So yeah, how have you found it?
So yeah, definitely they come sort of with a blank slate, this heaps of knowledge and theory. You can pretty much ask them anything and they know exactly all the nitty gritty of everything.
Yeah.
Which is beneficial from our side because we sort of move to the clinical side and you kind of forget if you haven't done neuro for a while and they've got a neuro patient, they sort of just open that file up in your head and you can sort of go, oh yeah, I remember what that was, and it benefits you as well. So you continue to remember stuff that you did previously.
Yep.
You learn a little bit as well. But I think the big thing is they sort of just lacking that confidence. Private practice, when somebody's sort of actually paying for a session with them, they are pretty nervous. So the biggest thing I think is confidence. Lacking sometimes a little bit with the hands-on skills.
Yep.
Depending on how much they've had. But I think especially the last sort of 2 years with COVID and things like that, they've sort of been limited at uni and stuff like that with the actual hands-on stuff. But I think just in general, biggest thing for them is just growing in confidence and using their knowledge in practice. Just that link is sort of lacking initially. I think with anybody coming straight out of uni,
it's sort of the connecting of the dots, isn't it? Like the base sort of foundation knowledge is often there. Like I found that recently where they had absolutely fantastic knowledge about I think it was like thoracic outlet syndrome or something, which is, pretty rare. But then the basics of sort of connecting the dots from a clinical reasoning perspective, and sort of, not being able to just categorize somebody into one box. You often sort of say like at uni, if they love extension and they hate flexion, it's a disc problem. But then the realization they kind of have in the early stages is it's not that easy.
No.
And patients don't just fall into their nice little neat boxes that you can kind of categorize them, and they kind of just it's not quite prescriptive as potentially they're sort of led to believe in university.
Yeah, and I think I was about to say, you sort of come out of university with boxes like lower back, upper back, neck, hip, and sort of actually just making one big box that sort of connects all of them is where we find they sort of struggle a little bit.
Yeah, confidence is the other. It's interesting to say about confidence as well, because that's something that we firmly believe at Health First Group that if a patient comes in, they should be given their diagnosis. There's kind of three things really that they need to know: what their diagnosis is, how long it's going to take to get better, and what the plan is to get better. Whether that's how many sessions, what sort of input they need. And if you answer those three questions, then generally clients are pretty happy. I guess the problem is that if you're a bit nervous about committing to that, and I think that's what a lot of the new grads are, is they're a little bit nervous to commit to the plan, then they struggle with that. Is that something you found? Because I often find they don't really want to give a very specific diagnosis, and they don't really want to give a specific timeline, as if there's a bit of a get out of jail card. But you've just got to kind of, I guess, trust in your diagnostic skills and stick to the plan, get the client on board and work towards that plan.
Yeah, I definitely find that them giving a diagnosis initially, especially for the first 3 months, is quite difficult for them.
Yep.
Their timelines as well, they sort of tend to underestimate.
Yep.
So that's sort of a big thing. But I think one of the big things I normally tell the new grads when I start is, I had a lecturer back at uni, because obviously you finish up, you're going out into the big wide world. Everyone's nervous. Our lecturer told us, you're the professional. We've given you all the info to go out into the world and treat patients and clients successfully. You're the content or the professional. They're coming to you for help. So if you give them a diagnosis and a plan, they should be sort of following that. And if you give that confidently, the patient gets confidence in you and sort of comes back and tells their friends and all that sort of stuff. But it makes you more confident when they come back, but they're confident in you as well.
Yeah, and you can always deviate from the plan if you sort of after the session feel that, well, I just want to run a few more tests and do a few more objective tests when they come in, and then you do, and then you sort of change and you discuss it with your supervisor. You can always deviate from that plan. But it's a bit like if you were to go see, like if I went to see a GP and they told me, oh, it might be this, or it might be that, or it might be this. I'm not 100%, but could you come back in a week? I'm going to go and see a different GP, I think. And that's the same, isn't it? Sort of, be confident in your diagnosis, create a plan and portray that plan and tell them what that plan is, and then go from there.
Yeah, and I also tend to say to them, with confidence, look like a duck. So nice and calm on the surface. Underneath, you paddling for dear life, but the patient can't see that. So as long as you portray confidence, they'll have confidence in you.
Good advice. Perfect. Any other sort of advice generally for people earlier on in their career, having worked with a lot of new grads and sort of less experienced physios? Are there any other tips or things that you sort of recommend for people that are interested in private practice?
Be like a sponge, so absorb as much as possible, sitting in sessions with your senior physios within your clinic.
Yep.
And don't be afraid to ask questions.
Yeah, good.
So even if you think it might be the dumbest question, just ask, because otherwise you're going to sort of never ask, and 5 years down the line you should go, oh, I should have asked that 5 years ago.
Yeah.
So just pretty much ask if you're unsure. There's no such.
It's you're right. It's like it's interesting you said about like be like a sponge, because I guess in those I found that you sort of go in reasonably confident, and then you start to realize there's a lot of information you don't know, and then it sort of opens everything up again, and then you kind of come back around again once you start learning everything, and you kind of get a little bit more confident again. But I mean, the beauty of our profession is it's always changing. There's always new research. And there's always somebody who's going to disagree with a certain research paper and a certain opinion. And over time, I say to the sort of new grads, this researcher might think this, and this person might think this. And, when you're a new grad, it's hard to get your head around. You sometimes have to just kind of meet in the middle and take a little bit of everybody else's opinions and then formulate your own opinion. Because it's not always black and white. And I think a lot of the members of the public would probably be surprised at that, is that it's not black and white. It's often quite grey, and there's often different opinions as to how to get to the outcome.
And that's what I find one of the massive advantages of sort of the growth of Health First Group now, as well as we've got so many physios with different years experience from different walks of life, from different countries, different universities, and everyone clinically reasons differently, and everyone can give their input. So with, like, for instance, the flow post-op, a case there, and you get so many different sorts of input in there, things you may not have thought of before. And that's what I try to do with the new grad sessions as well. So as their confidence grows, I like making them a lot more interactive. So getting input from all the different new grads as well, because they're all from different universities, have been taught slightly differently, all sort of get to the end goal in the end in a different manner, but it helps educate us all on different ways of getting to that goal.
It's good, isn't it? Somebody, we've got an internet system called Flow, which people post on quite regularly, and there's questions in there, and often people don't want to post in there, they're a bit shy, but when you do, there's some great input in there. We've had some sort of great TMJ questions for jaw pain, which is an area that a lot of people wouldn't know much about. So, some good resources were thrown in there. There's some sort of interesting diagnoses that I'd never heard of, which is, like I say, you're sort of always learning. And then, because there's 50, 60 physios, there's lots of different opinions on those and different articles to read and things. So it's just a really good resource, and people need to sort of take advantage of it to keep that learning process.
Yeah, I must say from flow, there's a couple of diagnoses that I've sort of gone, I have no idea what that is.
Yeah, I know. I was thinking, I've been a physio for like, I don't know, 13 years or something, and I was thinking, I have never heard of that in my life. But then, and I was thinking, surely no one else has. And then there was loads of people that gave loads of information. I was thinking, that's great. I had no idea what that was.
Yeah,
So,
no, it is. It definitely helps us all grow.
Yeah, it's good. So have you yourself, have you got any particular sort of things you like treating the most, or areas that you kind of are more passionate about from an MSK perspective?
So I really enjoy sort of treating ankles and knees. I really find those fun joints to rehab. But I have sort of I really like treating a lot of tendinopathies as well in general. So no matter where they are.
Yep.
I did a sort of sports course about a year and a half ago now, and they had a big section on tendinopathies.
Yep.
And sort of just flicked a little light switch on after that. And I really enjoy rehabbing those now. So.
And are you in the camp of sort of overloading? Are you in the camp of not overloading? The old sort of method of treating those and pushing through the pain and stuff, or what's your sort of current sort of methodology for treating tendinopathies? Because my understanding is obviously depends where they are on that continuum as to how you would treat it. But what's your sort of take?
So I've started treating a lot of them now with sort of progressive overload.
Yep.
So keeping load in a tendon. So tendon anatomically, physiologically supposed to have load going through it. So there's a lot of talk of activity and tendon capacity. So tendinopathies develop when your capacity outweighs your activity outweighs the capacity of the tendon. But the problem is, as soon as you rest, the capacity lowers of that tendon. So you're going to go back to your activity and have that endless cycle of pain.
Yep.
So I found sort of treating tendinopathies now, if we keep load, even if it's as basic as walking, sort of decrease it and then progressively load it, they respond a lot better than sort of resting completely and then trying to get back to things. So
good.
Working really closely with the patient, what their activities are, what their goals are, and then just explaining that there will be a bit of discomfort. So 3 or 4 out of 10 is sort of acceptable.
Yep.
As long as pain's not continuously increasing, that you're having good days and bad days, that will sort of stabilize over a period of couple of weeks, depending on how long it's been going on for. So it can be anywhere from 6 weeks to 16 weeks. I've had some clients sort of going.
The activity modification is pretty important, isn't it? And I always remember getting lots of sort of coming into like final season and they want to be perfect, and you're thinking, if you can get through it and play your finals, then let's deal with the problem afterwards.
Yeah.
Because it's very much what their goals are, and their goals are sometimes to just be able to play in 2 weeks and I don't care afterwards. The other people is the priority to get better and make us 100% recovery. But yeah, like I say, listening to what their goals are is quite important. What are you a fan of shockwave for your chronic like tendinopathies? You have pretty good results with that?
Yeah. So we use shockwave quite a bit in the clinic. So I've been using shockwave since I started with you guys from up in Mount Isa. Definitely find really, really good results with that. Especially even your acute cases get good results. Chronic cases can sometimes obviously take a bit longer, but getting good results with that together with exercise, overload, activity modification. So just looking at all those aspects and getting good results with that.
Yeah, good. I used to use it a lot for chronic tendinopathy stuff, but also like plantar fasciitis. So I've found that it's just kind of a sort of a good treatment option for things like plantar fasciitis, where conservative stuff hasn't worked. From a next level up in regards to injections and surgical options, you don't really want to consider from a efficacy perspective, and therefore shockwave can be a nice addition in there, and you see some pretty magical results with it.
Yeah, no, we definitely see really good results, and we've got a good relationship with they call him the foot surgeon in town. So he'll get people with chronic Achilles tendinopathy or plantar fasciitis referred to him for surgical intervention.
Yep.
He'll send them through to us for shockwave. We trial that.
Yep.
That works 95% of the time.
Yeah, good. Does he in the 5%? Does he look at surgical options? Because
yeah,
I presume cortisone is the first, and then following that, what sort of surgical options? Is it debridement stuff, or?
So he does a plantar and a gastroc release.
Yep.
So that's his sort of method. And then post that, he refers them back to us for post-surgical rehab. So he has really good results with that. So
I've never seen great results with surgical options. So it's interesting to hear that they are getting good results. It's been a while since I've seen that stuff. But I mean, I used to find the cortisones used to have pretty average results because you can't not walk on your foot. So do you know what I mean? You're not really able to go through that reducing inflammatory phase that you need post injection because it's your foot. Do they do that as a first port of call there, or not really?
Sometimes he does the cortisone, but a lot of, and he doesn't do just the fascial release. He does a gastroc release as well because he finds better results with that. So that's his standard surgical protocol. Other surgeons will just do a plantar fascia release, but he finds that link between the gastrocs and the plantar fascia, releasing that tightness through there as well gets him a lot better results.
Older population or sporty stuff as well, or?
The surgical population for that, sort of your older population, plantar fasciitis for 5-10 years. So
yeah, good. It's good that, like you said, you're getting a pretty high success rate anyway with shockwave. So obviously that gets a good outcome.
Yeah.
All right, perfect. Good. That's all the questions I had today, Jarryd. So anything else you would like to add at all?
No, I think that's pretty good. So
we've got a new bunch of new grads coming through next year. So I'm doing the interviews at the moment. So that's all filling up. And I know you're doing lots of work with the guys on limited registration and the mentoring for those guys. So thank you very much and keep up the hard work. And
it's definitely a part that I'm really enjoying and growing into. So
good.
Enjoy sort of mentoring, training up, and just watching them grow as clinicians.
Good. It's often when you get a bit later in your career, you kind of want a little bit more than just seeing patients, don't you? And it's good that there's opportunities to do that. As we're a bigger company, we need people in there in those sort of mentoring spots and those slightly more sort of managerial positions, as opposed to just 100% clinical caseload, which I think a lot of people get a bit burnt out. I know I did. With back-to-back patients after a certain number of time. I read recently I don't know whether there's much truth in this, but I read recently the dropout at sort of the 5-year rate for physios is absurdly high. People stop being physios anymore based on burnout. I don't know whether you saw that. Did you see that at all? Or?
Yeah, I've seen that. It's sort of that 5 to 7 year mark.
Yeah, and just any reasoning why? I mean, there was no real reasons given. I think it was just like from a sort of an emotional empathy sort of perspective and lack of career progression and things like that.
Yeah, it's sort of burnout, and I think that's called compassionate burnout.
Yeah,
where people just get burnt out because they taking on everyone's load and problem, where you don't actually realize how much you're taking on. As a physio, you don't think you're not a psychologist, so you don't think you're really taking that on, but you actually take on a lot.
Yeah, you are, and you sort of every sort of half an hour or so, whenever you see a patient, you've got to have your best game face on. You've got to be smiley, and you've got to listen to their pain stories a lot of the time. So I'd agree with that. I think it is, you become a little bit compassionately sort of burnt out, but I look forward to a bit more sort of research into that, because there's not many physios out there, and they're very in demand, and we certainly don't want people moving away from the profession, so we've got to make some changes to try and improve that.
Yeah, and I definitely think it's just taking time for yourself as well.
Yeah, exactly. So, quality of life and having a sort of a good sort of work lifestyle balance. and you know, being able to sort of take some time as well, especially when things come along like new babies. Hey, Jarryd.
Oh yeah, definitely.
and plenty of sleep, which I'm not sure you're getting at the moment, but that's an important one as well.
That's what I did on my recent break. So I'm trying to get a bit of sleep. Just handed them off to family and took a nap where I could.
Perfect, good plan. And now you're back to the real world.
Yeah, yeah, but that's all good. Getting back into routine. So
perfect. All right, thanks, mate. Thanks for coming on. Thanks for the chat. I'm sure we'll get you back on in a couple of months' time and have a few more questions. But appreciate you coming on, and I hope you enjoy the weekend when you get there over in Bunbury and the weather stays nice for you.
Perfect. Thanks for that, Phil. Been great chatting.
Cheers, mate. Take care.
Yeah.
Stop recording.